Okay, so who am I and why am I interested in exercise in chronic lymphocytic leukemia? I have a PhD in exercise immunology with a research interest, well, exercise immunology as a whole, but a particular research interest in exercise oncology. So we've done various different studies at the University of Bath. One of them, the most similar to this one, was a myeloma study. And so we sort of saw some interesting feasibility outcomes. So it seemed like exercise was feasible in that group. So we sort of put in some funding, and we got some funding to do a similar study in chronic lymphocytic leukemia. So why am I interested in exercise? My exercise background was a professional football player. So I played for Scotland, hence the accent, and I played for Bristol City. So being here in a cricket ground is also the wrong place for me. Know nothing about cricket, a little bit more about rugby, but yeah, football is where I'm most comfortable. But I guess as an elite athlete, we underwent all sorts of really specific gold standard exercise testing techniques and body composition and all of those sorts of things, because we were trying to get that sort of 1% that would improve our performance. But what I think is that should be sort of expanded to the populations that are perhaps in the cancer world, for example, where that 1% is also very important for quality of life, not just this sort of like exercise performance for these professionals. So what we did was, this is our study. Before we look at the sort of longer term outcomes, we have to evaluate if exercise is safe and feasible in the watch and wait population. So this is what we, the title of our study: to evaluate the safety and acceptability of a progressive exercise program in chronic lymphocytic leukemia. And this was a randomized controlled pilot study. So we had an exercise group and a control group. So this is the CLL treatment pathway that Nil did an excellent job of talking about, and I think she'll go on to talk a little bit more about the treatment later on, so I won't do any more of that, other than it's often an incidental diagnosis, like Nil mentioned. So people are usually pretty active and pretty able. So in the watch and wait population, this is where we decided to intervene. Okay, because like I said previously, we've worked with myeloma, and again, they have this sort of active monitoring period as well. So this is where we intervened with our intervention. We had two questions that we wanted to answer with this study. Okay, the first question is exercise training safe and feasible? The second one, what impact does exercise training have on disease activity, physiological and immunological measurements? So this is our specific study design. What you'll see at the bottom there is a key that has the grey boxes were conducted in participants' homes, and the black boxes were conducted either at the Royal United Hospital or at the University of Bath. So up at the top, we did our participant identification with our clinician team, okay? So we had clinicians from the RUH, from Swindon. They were working together on this project to try and identify our participants. Then we did a screening. So this was either at the RUH or at the University of Bath. This included a resting ECG. So this was a safety measure because we didn't want anybody to start our study and have any sort of cardiac problems. And then we had consent performed by our clinician. So at the next point here, the black bar, this is where we had a really in-depth baseline assessment with all the participants that went through that identification, resting ECG, and then consent, okay? So this is where my sort of exercise and my football background came into it, and we did really what we call a CPET, which is a cardiopulmonary exercise test, and we've got a few of our participants in the room today, and they will hopefully tell you that wasn't terrible, but that was where we monitor the O2 and the CO2. So we put a mask on you, we did a submaximal exercise test, so we get a really, really in-depth idea of what your body is doing as we're increasing the intensity of exercise. And that is what is done gold standard across all sort of elite athletes. We did some fasting blood samples, we did some functional tests, so that was sort of sit to stand, a bit of strength exercise, just to get an understanding of where people were at baseline. We did body composition, and again, we used a gold standard technique called the DEXA scan. So that gives us a really in-depth idea of what muscle mass, fat mass, bone mineral density, that type of thing. And we did resting, heart rate, blood pressure, and some well-being questionnaires. Okay, so it was about an hour and a half, 2 hours maybe, in the lab with myself and it's one of our students. Then we sent people away to do some free living measurements of physical activity level and dietary monitoring. At that point, people were then randomized a little bit more detailed than just a flip of a coin into an exercise training group or a control group. If you were in the control group, you continued with standard care for 16 weeks. If you were allocated to the exercise training intervention, you did a 16-week exercise training intervention alongside standard care. So at this point, I want to draw your attention to the fact that this is also in a grey box, which means this was conducted at people's homes. Initially, when we got the funding for this study, it was pre-COVID, so it was 2019. And it was initially designed, like the myeloma study, for participants to come into the hospital and do the exercise in the lab, or in the lab at the side of the gym. But with COVID, I didn't want this study to stop altogether, so I worked with the funders and they were excellent. We were able to reallocate some funds to buy exercise bikes. And I got in my massive big university van and I delivered exercise bikes to everybody's homes. They were quite heavy. And then we started our 16-week exercise intervention, and it was supervised by Microsoft Teams. So that was also something we weren't sure whether that was going to work or not. So again, it's another sort of angle of this feasibility. Is it possible? So we had people on exercise, we had people on Teams, and we were telling them what to do, and on the whole, they were doing it, which was excellent. And it was really, really well prescribed. So I'll go on to the exercise intervention in a little bit more detail in the next slide, but it was completely personalized to each participant. So no two people were doing it exactly the same. It was completely individualized. And then the other thing we asked them to do was a once weekly unsupervised walk. After the 16 weeks, we then got everybody back in again in week 17 to do exactly the same measures as we did at week 0. So we were aiming for 20 and 20 because this is a feasibility study. That was sort of what we were looking for. Let's try and get 40 participants, 20 in each group. So let's go into the exercise intervention in a little bit more detail. There'll be some people looking at this and be quite familiar with this 16 weeks, I think. So what we've got at the top here is we've got our trial weeks, week 1 to week 16. So week what the different colours of blue basically indicate an increase in progression. Okay, so we start in week 1 and 2, just familiarising people with the intervention, getting them sort of, it's just getting people moving, and the intensity is quite low. Then that increases in weeks 3 to 6, a little bit higher, 7 to 10, a little bit higher, to then 11 to 16. The aim is to get people working at a really moderate to vigorous intensity during that period. And what we have here is, the pink is our supervised sessions, so that was mostly on a Monday and a Wednesday. Sometimes we adjusted that, depending on people's schedules, and then the unsupervised on the Saturday. So what actually happened during the formatting's gone a bit funky, sorry. What actually happened during the intervention itself? This was the bike that we delivered to people. And what you can see here, hopefully it's big enough, there was a 5-minute warm-up, followed by an 8-minute interval 1, followed by 2 minutes of active rest, followed by another 8 minutes, and another 2 minutes of active rest, and then a third 8-minute interval. Okay, so it amounted to 30 minutes of aerobic exercise in total. And the way that we prescribed this exercise was based on that very first visit that we had at the university. So what we did was we measured what we call the ventilatory threshold of every individual participant. That is the point at which you're exercising, where you have to sort of start breathing a little bit deeper because your body needs a little bit more oxygen, okay? So when you're walking uphill and your breathing starts to become a little bit harder, you can't talk as easy, that's your ventilatory threshold. And that is different for every single individual in this room, okay? So we took that ventilatory threshold, the work rate, so the work rate is the watts, that's how hard you're pedaling the bike. That is what we used to prescribe our exercise, okay? So in week 1 and 2, people worked at 5% below their ventilatory threshold. Then week 3 to 6, they worked at their ventilatory threshold. Then 7 to 10, it was plus 5% of their ventilatory threshold, and then 11 to 16, that's when it's getting a bit more vigorous, and that's plus 15% of their ventilatory threshold. The beauty of these bikes is the interface was really easy to use, and we were able to prescribe and get patients to put the wattage that we wanted them to work at using the bike. So we knew that they were working exactly at the intensity that we wanted them to work at for them to be at those different levels. Okay? If that wasn't bad enough, we then got them to do some resistance work, okay? Because when you think about the body as a whole, it's not just, and when you're thinking about exercise, the benefits of exercise are not just aerobic, there's also benefits to improving your strength, okay? Improving your muscle mass. It's really important, and especially in the sort of ages when you get a little bit older, it's really quite tricky to maintain that muscle mass, okay? So we added in the resistance exercise with these bands. There's some bands up at the back that we can have a go at later if you want. So session 1 was on the Monday, and we did 3 exercises there. So we did a chest fly, which works your sort of muscles across the chest. We did a tricep extension, which works your triceps down here. And we did a squat, which works pretty much your whole lower body. And the intensities in which we did those were in week 1 to 2, that was 2 sets of 10. Week 3 to 6, that was 2 sets of 12. And then 7 to 10, we ramped it up to 3 sets of 10. And then finally, for our vigorous intensity, 11 to 16, that was 4 sets of 10. So by the end of it, it was 40 exercises, 40 of each different exercise a week. So session 2 was the reverse fly, which is almost the opposite of the chest fly, so you're working your back. And then you had your calf raise, so again, that's isolating your calf muscles. And then you had a side lift, which is an exercise that sort of works the whole of the side of your body. That was everybody's favourite one. And then finally, we asked people to do their unsupervised walk in their own time over the weekend or whenever they could fit it in. And what we asked them to do was intensity of between 12 and 13 RPE. So RPE stands for relative perceived exertion. And if you think 20 is maximal effort, you're lying on the floor, you cannot do any more, and 1 is just absolutely nothing. We asked them to do between 12 and 13 on that scale. So reasonably, pretty easy walk, basically, for about 45 minutes. So let's look at this first question then. Is exercise training safe and feasible in people with watch and wait chronic lymphocytic leukemia? How do you even go about assessing that? These were our outcome measures for that, okay? We need to show that we have a reasonable uptake of, we need to show that people want to do this study, and they want to do exercise. We need to show when they agree to it, they actually adhere to it, and they do it. We need to show the compliance, so are we prescribing exercise that is okay for people to do, or is it too hard or too easy? We need to show that it's safe, and we need to show that people finish the trial. So, let's look at our recruitment then at the top. Using, well, you guys as well, using the CLL support advert, using our clinicians at the RUH and in Swindon, we invited 100 participants to take part in this study. We had 52 decline for various different reasons, and we actually managed to get 40 participants recruited and consented for this study. Following that, we had 11 participants that were excluded following the in-person screening. Of particular interest in that one is that 9 participants were excluded due to a cardiac abnormality that appeared in the resting ECG. And then, so following those 11 patients that were excluded, we had 28 randomized into either exercise or the control group. Okay? So that meant that we started this study with 14 exercisers and 14 in the control group. During the intervention, we had 3 exercisers discontinue for various reasons, and we had 1 control participant discontinue, which meant that we had 11 participants to analyse in the exercise group, and we had 13 in the control group. So let's have a look at the feasibility then in particular. Let's have a look at these various different outcome measures that we have to look at. Recruitment was open for 15 months between October 2021 and December 2022. The uptake was 40%, so 40% of people attended the in-person screening and then consented. It's pretty usual with these types of studies. 73% of people that attended the in-person screening were deemed eligible. Like I mentioned on the previous slide, they were excluded for various different reasons. 70% of the consented participants started the intervention. So that, in terms of the uptake, that's pretty good uptake numbers. The retention, so 86% of participants that started completed the intervention, which is really excellent. And we had 79% retention in the exercise group and 93% retention in the control group. That is particularly good. What often happens in these studies is if you are told, I mean, often people that sort of volunteer for these studies, they do want to be in the exercise group, which is understandable. So if they are randomized into the control group, some people do drop out. But what we had was a really high retention, which is, I think that's excellent, and I think that's testament to people with CLL and how engaged they are in wanting to learn about the condition and help in any way they can. Adherence. This was excellent as well. Everybody turned up. So attendance at our supervised sessions was 92%. And then the unsupervised home exercise was 79%. So again, very good adherence. The compliance was excellent as well. So we had 99% compliance to the duration. So that means that 99% of participants did that full 30 minutes of exercise that we wanted them to do twice a week for 16 weeks. And then the resistance bands. And 100% compliance to the intensity prescribed. So the intensities that we prescribed for every individual participant was okay for them because they completed what we wanted them to complete, and they coped with the progression from the sort of low intensity all the way up to the vigorous intensity, which is excellent. The resistance exercise, again, 99% compliance to the sets and reps prescribed. And then the unsupervised home exercise, so 99% compliance to the duration of exercise. And the mean RPE was 12, which again is what we'd asked people to do. So everybody did what we asked them to do, and that was fab. So we are pretty confident that we can say that this study showed that this progressive exercise intervention was feasible in people with watch and wait chronic lymphocytic leukemia. So let's go through the safety, which is another important thing when we're dealing with these types of studies. The incidence and severity of adverse events is one of the things that we need to report. We need to make sure that we're not causing lots of adverse events as part of this research. So we just had one adverse event, which was fainting following the submaximal exercise test, which was, of course, related to the trial because the participant was in our lab. We also had one serious adverse event, which was a hospitalization, but that was unrelated to the trial. That would have happened regardless of whether they had taken part in our trial or not. And one of the things that was a little bit of a surprise to us, perhaps, was the importance of doing these resting ECGs in participants, because we had 9 excluded due to cardiac abnormalities that weren't in the participants' medical records at all. So these were screened by cardiologists as well from the RUH. So we had a cardiologist on the team that we sent these ECGs away to. So they were. What I will say about this one also is that they were really conservative because we were asking people to exercise at home. We had even less control over whether there was any sort of safety. We did blood pressure with participants before they started their exercise, but we didn't have, if there was any sort of incidents, cardiac related, we couldn't be there instantly. So we were really conservative with this. Okay. So, second question. What impact does exercise have on disease activity, physiological and immunological measurements? So we've covered the primary outcomes. Let's move on to our secondary outcomes. So at week 0 and at week 17, we did this battery of tests, as I mentioned previously. We were looking at blood tumour cell frequency, we were looking at physical fitness, we were looking at body composition, heart rate and blood pressure, and various T cells, because we are also, like Neil mentioned, it's a B-cell cancer, but your immune system is combined of both your B cells and your T cells, and we are sort of interested in both parts of it. And then we did a couple of control measures at the bottom, so had a look at dietary intake and then general health status. So the participant characteristics, these are the participants that took part in this trial. You have the control, which is 13 participants, and then you have 11 in the exercise group. So I said it was slightly more advanced than a flip of the coin to randomize participants. The way that we did randomize was stratified based on sex and age. So we wanted to make sure that we didn't have a skew towards one sex in one population or a skew in age. And I think this did a pretty good job of stratifying, so there's no difference between the ages between the two groups, so they were both just over 60. We had a pretty even split of males and females in both groups. And what I will mention here is this p-value at the end. Is what we do with these studies is we look at all of the data and we do some really detailed statistical analysis to check if our intervention is making any significant change. Okay, so what you'll see down here is the p-level below 0.05 means that there's a statistically significant change there. Anything that says NS is you might visually see slight changes, but we can't be certain that that's the result of the intervention and not just the result of chance. Okay, so what you'll see here is there was no difference in body mass between the two groups pre to post. There was no difference in BMI between the two groups pre to post. There was a significant decrease in both systolic and diastolic blood pressure in both groups from pre to post. So they decreased post in the week 17 measurement. And we think that's the result of what you call a white coat syndrome, really. People were uncertain and unfamiliar with the lab the first time they came into the lab in both groups, both the exercisers and the control group. And then they had experienced it before, so they were sort of more familiar with it in the post visit. So I think that's the shift there. And you can kind of see it a little bit in the resting heart rate as well, although it's not statistically significant. Okay, so here's the cardiorespiratory and functional fitness. Immediately, I'm sure you'll see that there's no statistically significant changes in the pre to post values in the control or the exercise group. But again, what I would say with this is if you look a little bit closer at the data, so if we take the first one, for example, which is the cardiorespiratory fitness, this is the VO2 at ventilatory threshold. So VO2 this is what you would sort of see as if you do a VO2 max test and people say, oh, my VO2 max is 16 mil of kilograms per minute. That's pretty high. But this is the measure that we would use for that sort of total fitness level. And what you'll see is that there's a slight sort of almost a slight increase in the exercise pre to post, where a little bit of a decrease in the control pre to post. But again, it's not statistically significant, but things are moving in the right direction. This trial was not powered to see this, to look at these particular measures. So this trial was to look at feasibility. What we would do next is we would power a study to see significant differences in measures like these, which would mean that we would need more participants, and that's basically the aim for this, is to sort of show that in a pilot study, things are moving in the right direction. So let's apply for funding to do a bigger study. But like I said, things did move in the right direction for our cardiorespiratory fitness up at the top, and then we've got our functional fitness, which was tests of balance, tests of strength, and then a couple of flexibility measurements down at the bottom there. So let's go on to some body composition then. This is the DEXA output that you get. It's almost like a scanner. You lie in the scanner, and it's like a sort of X-ray machine almost. And this is the output that we get from it. So you see the fat is in sort of the yellow colour, the lean, or that's muscle mass, also known as, is the kind of red to pinky colour, and then the bone is the blue colour. So the control group, there was sort of no real changes in the body fat percentage. Looked like it decreased a little bit, but not significantly. Gynoid fat is the section. This is the gynoid section here. So it's your sort of hip section, as opposed to your android, which is up here. And then the total fat mass, again, slight decrease, but it wasn't significant. And then the lean mass stayed the same, so that's your muscle mass. And then the bone mineral density decreased slightly in comparison to the exercise group. So the exercise group, the body fat percentage decreased slightly again. The gynoid fat of interest, that was significant. So there was a significant decrease in the percentage of gynoid fat from 36.4 to 34.8, which is probably indicative of the type of exercise that we were doing with the participants, because they were on the bike, and so there was a lot of sort of movement of the gynoid region. And then of real interest is the lean mass, okay? So the lean mass is also that's a whole body muscle mass is what that's measuring. This increased from 48 to 49. So it's a whole kilogram increase of muscle mass, which is really impressive in this population. This is a population of slightly older than 60, and that is as you age, your muscle mass does decrease. So for us to be able to increase the muscle mass in this population was really excellent. And this wasn't just one participant skewing the data in any way. This was every single participant that was in the exercise group increased their muscle mass. Some of them by 2.5 kilos. It was really, I was quite surprised that we found this because, like I said in the previous slide, this study wasn't powered to find these types of significant changes. It was a feasibility study to sort of explore and see what happened to these measures. So it was, I was really encouraged to see that. The other thing that it wasn't significant, but I think is still of interest, is the bone mineral density at the bottom. So bone mineral density is another thing that we need to be really cautious of as we age, and especially in women. Resistance exercise and loading exercise is one of the things that really does help to maintain bone mineral density. And we saw that in the exercise group, pre to post, we were able to maintain that level of bone mineral density, whereas in the control group it seemed to decrease a little bit. Okay, let's move on to the blood analysis now. So we did flow cytometry on the blood samples that we got, which it's a technique in which you add antibodies to the blood, and that identifies the exact phenotype of the cell, so what they're expressing on their cell surface, and that allows us to identify what types of cells they are. So what we see here is at the top you've got your total white blood cell count. So that's what, as Neil probably mentioned, that's probably what people do track when they get their bloods done from the hematologists. And what makes up your total white blood cell count is your T cells, which is broken down into CD4 T cells and CD8 T cells. There are two different types of immune cell within your T cells. And then you've also got your B cells below that. So the B cells in this table currently are the B cells that are not CLL cells. So they're not your clonal CLL cells. So that's almost your immune system without the CLL cells. And what you can see here is there was no significance to any of these numbers. So if we go on to the clonally restricted CLL cells, so this is your kappa or lambda restricted CLL cells, and at the top here, again, there's no significant difference, and with a study like this and with the variability of the counts that participants have, it's going to be very, very difficult to see any statistically significant difference in these counts. But yeah, there's the raw figures for you. And then the other two markers that we used at the bottom, so CD49D and CD38, are flow cytometry markers to look at prognosis. So Neil mentioned the other two ways of looking at prognosis. These are the flow cytometry, the way that we look at those in flow cytometry. And again, there didn't seem to be any statistically significant change there. We did a validated quality of life questionnaire with our participants, and it didn't seem to pull out any statistically significant information. The one that is significant is pain, but it seemed like the control group just seemed to have a little bit more pain, both pre and post, than the exercise did. It's not related to the trial at all. Again, with these types of big questionnaires, they're better in a sort of big population, but it's still of interest, I think, to look in these smaller populations, because if I draw your attention down to the CLL-specific fatigue, down at the bottom here, it seemed to decrease by 10. So this is all out of 100, which it didn't change between pre and post in the control. It went from 21 to 22 in the control, but then it did decrease from 18 to 8 in the exercise group. So I think, again, things are moving in the right direction. They're just, we don't have any statistical significance because of the size of our study. So I'm going to move on to talk a little bit about the participants' point of view, because I got some quotes from the participants that we had in our trial, because it's important, of course, for us. I've just sort of bored you with a load of data, but did the participants enjoy it? Was it something that they would continue to do? I think that's a real key thing for us, because I think that's testament to the adherence that we had and the compliance. So I was keen to be able to help with anything that might be of use. To be of use to help clinicians understand and treat those with CLL. It was enjoyable to take part in the trial and fun to speak to other CLL patients while we were online together. Made me more aware of the importance of maintaining my physical activity. Strong memories about the trial. It came into my life during some dark days and helped me focus with the sense of routine and newly found purpose. I'm so glad that I had the opportunity to meet the researchers. Obviously, I wish under different circumstances it would be nicer. If I helped in any way in your trial, then this was my pleasure and it was worth every minute. This one, I'm a physiotherapist, so I was interested in finding out the benefits of exercise on my condition before hearing about the trial. I really enjoyed taking part in the trial and knowing it was helping not only my own health, but enabling researchers, which could benefit others. Having the exercise bike at home and the exercise sessions on Teams made taking part very feasible. The researchers made the whole experience really enjoyable, and I enjoyed meeting other people with CLL. I missed it when the trial was finished. I'm pleased that I took part in the study, as although I already did some exercise, it pushed me out of my comfort zone and has left me feeling more positive about the future, giving me a way to fight back. Watching and waiting can be quite lonely, so it's good for me to meet other people in the same place. I think that I eventually enjoyed the biking too, and even got quite fond of the bike, which took up residence in our conservatory for 4 months. Just when you think you're quite fit, along comes this trial, pushed some boundaries, but it was so worth it. Enjoyed it immensely. I always had a sedentary job and was not really particularly keen on exercise. I'd take the dog for a walk every day and went to a Pilates class once a week. When my consultant first suggested I did this CLL exercise trial, I thought it would be a good opportunity to have a reason to do some exercise. I was surprised I actually really enjoyed it and looked forward to the exercise sessions. It was good to be able to do the exercises at home and have the interaction with researchers. I was really unfit when I started the trial, and in the battle with the bike, I came near to collapse. But the big sisters, I think he's talking about me and Rachel in this, were watching and got me sorted out. So I didn't collapse, and in fact went on to add 2 kilos to my muscle mass, which was nice. So at that, I will let Sue come up and talk a little bit about her experience of the trial itself.
Hi, my name's Sue, and I was diagnosed with SLL in November 2020. Sorry, I'll put my thing on the screen. After the usual shock of diagnosis, my background as a physiotherapist meant I was immediately interested in any benefits of exercise on my condition. However, when I inquired, I was told there was no research done into the effects of exercise on CLL. So when I finally saw a consultant for the first time 6 months later, I was delighted to hear that there was to be a clinical trial based at Bath University looking at exercise and CLL. I was very keen to take part and delighted to be selected to be in the exercise group. I found the whole process of being part of the trial interesting, encouraging, and fun. I enjoyed having an in-depth study of my fitness, and I live very close to the university. It was easy to get to the bits that were there in the lab. And the only uncomfortable thing was the seat on the exercise bike in the lab, which was extremely painful. I took my own cushion. It was encouraging to feel that I was getting fitter, and I found the gradual build-up of exercise with the static bike and the other exercises very doable. And it was reassuring having the guidance of Frankie and Rachel on when to increase the difficulty. And the weekly walk was an enjoyable variation in type of exercise. I think the home-based nature of the exercise sessions and using teams online was absolutely crucial for the trial's success in recruiting and enabling patients to complete the trial. I found the range of times offered for exercise sessions made it convenient to fit into my week, and I think I only missed one session because of a holiday. I only work part-time now, so it might have been harder for those working full-time. Since my diagnosis, I haven't actually sought out others with my condition, but I really enjoyed meeting others with CLL and feeling part of the group. And it was great to chat to others in the sessions. We could talk as well. We weren't exercising at too bad an intensity. And it was really good to see people grow in fitness and in confidence and in benefits to their mental health. Lastly, I would like to emphasize how Frankie and Rachel had such a positive impact on my experience of the trial. They were both so friendly and chatty and really helped the groups on teams to get to know each other. They were very encouraging and endlessly patient when some of us struggled with the tech and the bike settings. I was sad when the trial finished, as I had enjoyed their company in the sessions so much. And I'm sure taking part in the trial has contributed to me remaining very well, and I'm very grateful for the opportunity to be part of it.
Thanks so much, Sue. I think that was perfectly put. I've just got a bit of a summary, final summary, and then we'll open up to questions. So this 16-week personalised progressive exercise training programme was safe and feasible in people living with treatment-naive CLL. The 16 weeks of exercise didn't reduce the CLL tumour load. However, further investigation is certainly required. The role of T cells will be important to understand within that. 16 weeks of exercise reduced body fat and increased muscle mass, which was hugely encouraging. And then the resting ECGs were a hugely important safety measure within this trial. I have some thanks, firstly, to our funders, the World Cancer Research Fund, my colleagues at the University of Bath, our colleagues that we worked with at the NHS, both at the RUH and Swindon. Thanks to the conference themselves, thanks to the CLL support for firstly advertising our trial and secondly inviting me along to chat to you today. And I will continue to work to try and sort of help in any way I can. So thank you very much.